Hello, I'm happy to be here today with you to discuss naloxone use for first responders. This program came about as a result of the high increase of opioid deaths over the last several years. And the Indiana State Legislature decided to increase the scope of practice of emergency medical responders and EMTs. So this program will be your training for using naloxone should your fire department choose to use it. So in the next couple of slides, we'll discuss very briefly our objectives and what we're going to be going over. We're going to discuss opiate overdose problem, both nationally and state and local statistics. We're going to describe the Indiana legislation that allows first responders to administer naloxone. We're going to recognize some common names of opioid drugs. We're going to recognize the signs and symptoms of an opioid overdose, describe indications and contraindications for naloxone, and talk about naloxone pharmacology. We'll also describe the supplies and equipment that you'll need to properly administer naloxone, demonstrate proper naloxone administration, describe possible responses to naloxone, describe the management differences for a patient without a pulse, demonstrate providing continued support to the opioid overdose victim, and we'll discuss the opioid overdose BLS protocol. The first thing we'll talk about is the national problem. The majority of drug overdose deaths involve opioids in the United States. 91 Americans die every day from an overdose of opiates, and deaths from prescription opioids have quadrupled since 1999. This chart is from the Centers for Disease Control, and they show the overdose deaths involving opioids in the United States from 2000 to 2015. As you can see with the green line on the top, with any opioids, there is dramatically increases beginning in about 2013. As you go down through the chart there, you see commonly prescribed opioids next, which are natural and synthetic opioids and methadone. And then you see below that is heroin, which is obviously an illegal drug, but you see the sharp increase going up starting in about 2010. Then at the bottom you see other synthetic opioids such as fentanyl, and you see a dramatic increase there beginning in about 2013. And in Indiana, the problem is just as bad, if not worse, than at the national level. You see in this slide the total drug overdose deaths have increased 625% since 1999. And that's total drug overdoses, so that makes up all drugs. You see the breakdown in that since that same period, since 1999. Heroin drug deaths have increased 4,200%. Opioid pain relievers deaths have increased 1,000%. Cocaine 175%. Other narcotics are at 400%. Benzodiazepines are at 1,200%. Psychostimulants are at 950%. And other drugs are at 800%. So there's been a huge increase over the last 16 or 17 years from all drug overdose deaths. And to me, this is one of the most interesting slides in the whole presentation. It shows the overdose problem by county, and I selected counties in our area, in our regional area in Indiana. These are county deaths for all drug overdoses from 2011 to 2014, and the way the Indiana State Department of Health ranked them by population. So the first number is the actual number of deaths in that 4-year period, and the second after the number sign is the county rank from the state of Indiana. So you see in Crawford County there were 5 deaths attributed to overdoses in that period, and that ranks Crawford County at number 60 out of our 92 counties. Harrison County had 22 deaths with a rank of 49. Washington County had 27 deaths with a rank of 27. Orange County had 8 deaths with a rank of number 67. Perry County had 8 deaths with a rank of number 65. Floyd County had 57 deaths with a rank of 26. And Clark County had 109 deaths with a rank of 12. So next we're going to be looking at the Indiana legislation that gives emergency medical responders, or EMRs, and EMTs the permission to give naloxone. This first piece of legislation, or this first IC code, as you see, defines what an overdose intervention drug is, and the legislation does not refer specifically to naloxone. It refers to an overdose intervention drug, but this IC code defines that overdose intervention drug as naloxone or any other drug that is an opioid, opiate, or morphine antagonist. An antagonist simply means something that works against the opioid, opiate, or morphine. And next at the top, this IC code grants permission for a paramedic, advanced EMT, EMT, EMR, firefighter, law enforcement officer to give naloxone to an individual who is suffering from an overdose. The second IC code grants permission for healthcare providers who can write prescriptions to prescribe naloxone for paramedic, advanced EMT, EMT, EMR, firefighter, or law enforcement officer. And the third IC code gives permission to a pharmacist to dispense a valid prescription of naloxone to these same individuals. So in this one IC code, you see that these are subletter A, B, and C. In this one IC code, you have permission for these individuals to give the naloxone, permission for a physician or anybody else having prescriptive authority in Indiana to write a prescription for the naloxone, and you also have permission for a pharmacist to dispense that prescription. So as we move on through the legislation and the IC codes, the first IC code grants civil immunity to a paramedic, advanced EMT, EMT, EMR, firefighter, or law enforcement officer for giving naloxone to someone with an overdose for acts or omission except for gross negligence or willful misconduct. So this IC code protects those of us giving naloxone for any wrongdoing that might occur, with the exception of gross negligence and willful misconduct. And those consist of things such as if you would intentionally try to hurt someone or something like that. The second IC code requires a paramedic, advanced EMT, EMT, EMR, firefighter, or law enforcement officer who administers naloxone to report to the transporting ambulance service the number of times naloxone was given. Further requires that the transporting ambulance service to report to the EMS Commission this data, including any naloxone given by family members, friends, or anyone else that might be present. So what's going to be important with this is, for the fire departments, it's going to be very important for not only for you to tell the transporting ambulance service how much you have given, but also try to find out if someone in the home has given naloxone to the patient prior to your arrival. So let's discuss for a short time exactly what are opiates and opioids. You've probably heard me throughout the beginning of this presentation use both of those terms. Technically, opiates and opioids are different. However, for our purposes, we'll consider them to be the same. So regardless of which term you want to use or which term you hear me use in this presentation, essentially for the purpose of this naloxone presentation, they are the same. They are a natural or synthetic drug like morphine, with morphine-like activity. Opioids are used in medicine as pain relievers, so they're very commonly prescribed by physicians and others with prescriptive authority. They act on specific receptors of the brain, but they can also be highly addictive, so that's part of the dangers of the opiate problem. Their effect is to depress brain function, which is where our breathing is controlled. So opioids effectively slow or stop the breathing when used in higher than recommended doses. And naloxone competes for those same receptors in the brain as the opioids do. So as the naloxone takes the place of the opiates as they are metabolized, the naloxone takes the place at those receptor sites, and the opiate therefore cannot bind to those receptor sites, so it doesn't have that effect. Okay, so let's look at some common names. There are a lot more names than I've listed here. These are some of the more common ones, but there are a lot of names, generic names, brand names for opioids. One that everybody has heard about is obviously heroin, which is an illegal drug. It has no medical purpose. Going down the list there, I'll quickly go through these. You see initially the generic name is listed, and then you have a brand name if it's applicable. Suboxone, which is the second on the list there, and we'll talk about that here in just a little bit, is used as a for opiate addiction treatment programs. So we'll talk about that here in just a minute. Stadol is a very popular medication used in emergency rooms, ICUs, and those sort of things. Codeine is in a lot of things. Can be in cough syrup, can be in pill or tablet form. Fentanyl, which we'll talk about more here later, it's one of the things that it's used for is as in endurogesic patches, which is a patch that can be put on the skin, and the fentanyl can be absorbed through the skin over a long period of time. Hydrocodone is also known as Vicodin or Norco. Meperidine is also known as Demerol, and then we mentioned morphine already. Nubane is also very common to be given in emergency rooms. Oxycodone or Percocet is common as well, both in tablet form and in injection form. Oxymorphone, Tolwan, Paregoric, and Propoxyphene or Darvon. So these are just a few of the names. There are many more as well. So now we'll talk about some common characteristics of opioids. After prolonged use, a tolerance to the drug tends to occur. This requires increasing the amounts to achieve the same effect. This occurs whether the drug is an illegal drug or taken illegally or a prescription drug. So people who have chronic pain will oftentimes develop a tolerance to their pain medication, and they have to take stronger and stronger medications or more and more amount of those medications. Some common side effects that opioids can cause are nausea and vomiting, drowsiness, lethargy, itching and flushing, dry mouth, small or constricted pupils, and constipation. Heroin, which is illegal as we've mentioned before, can be inhaled, it can be snorted, injected, smoked, or swallowed. It has a lot of street names, and we're not going to go over those here because there's probably at least 20 or 30 different street names that heroin goes by. There are different types of heroin. There's white heroin, brown heroin, black tar heroin, and for our purposes, we're not going to go through those different types. One of the dangers of heroin are the impurities in what is used to cut the heroin. By the time the user gets it on the street, the heroin is not pure heroin. It has been cut or diluted to make the pure heroin go longer into more doses and that sort of thing. And there's a lot of things that are used to cut the heroin. Some more traditional ways are listed here: caffeine, flour, chalk, talcum powder, sucrose, starch, and powdered milk. In the last few years, however, we've seen fentanyl and carfentanil being used to cut heroin, And this is extremely dangerous, both for the user and for the first responder as well. Fentanyl is 100 times stronger than morphine. Carfentanil is used in veterinarian medicine as a large animal sedative, and it's used on animals such as elephants, lions, tigers, and those sorts of large animals. Carfentanil is 10,000 times stronger than morphine and 100 times stronger than fentanyl. The danger of carfentanil is that it's used to cut heroin is that it can be a danger to the people in the area of the drug, not only to the user. Carfentanil can become airborne and can be absorbed through the skin. So if you come into contact with carfentanil, the drug can affect you through inhalation and absorption through your skin. So now we'll talk about some carfentanil safety measures. It's very important that you maintain situational awareness at all times. Don't walk into a residence with tunnel vision. Make sure as you walk in that you look around, that you know who's around you and what kind of things that might be in the area. If bystanders or first responders are showing symptoms, you might need to think of it as a hazmat situation. The National Institute of Occupational Safety and Health, or NIOSH, classifies fentanyl as an incapacitating agent. Avoid touching anything you don't have to touch or staying within the scene longer than necessary. One way to think of these scenes is that of a crime scene. So try not to move anything you don't have to move to treat the patient, or touch anything you don't have to touch. If a first responder begins to feel ill, stop and seek care for them immediately. Carfentanil and fentanyl require large doses of naloxone to reverse the effect. Some medications you may see around drug users, are addiction and treatment drugs. Methadone, Suboxone, and Subutex can be used as pain relievers, but are most often used in addiction treatment. So this will give you an indication when you're doing your history. If you have these medications or they give you these medications, it might indicate that they are in addiction treatment. One of the things that's very important to recognize is what are not opioids, because naloxone only works on opioids. It doesn't work on other types of drug overdoses. So it's very important to know what opioids are and what they are not. So this list of medications here are things that are not opioids, such as cocaine, LSD, ecstasy, sedatives or tranquilizers, marijuana. Benzodiazepines, as we saw in a chart earlier, are a huge class of drugs that are abused as well, but naloxone will not do any good for these type of overdoses. And benzodiazepines include medications such as Valium, Versed, Xanax, Halcion, Ativan, Restoril, and Klonopin, and there are other names as well. So let's look at some individuals who are at risk for overdose. One of the first red flags should be individuals who are getting narcotics from different physicians. Oftentimes people who are abusing prescription narcotics are going to different doctors to get their drugs, and they're not telling all the doctors who they're going to. So one doctor doesn't know that a previous doctor has already prescribed something for them. Users of drugs prescribed for others. Users who inject drugs for greater effect. People in drug treatment programs. Elderly patients using opioids for pain. It's not uncommon for elderly patients who have, especially people who have chronic pain, to be in more pain one day and take an extra dose of their medication, or for elderly people possibly with dementia to forget that they've taken their medication for that day and go back and take it again. That's not uncommon at all. Also, patients using pain relieving patches incorrectly. Patches such as fentanyl or duragesic patches can be chewed, and they get the medication much quicker than when it absorbs through the skin. And also, don't forget children who accidentally take medications that are found in the home. So now we'll look at some signs and symptoms of overdoses. Patients who are unresponsive to verbal or painful stimulus. Patients who are not breathing well or not breathing at all, less than 6 breaths per minute. patients that have cyanosis or a dark bluish tint to their skin, nails, lips, and mucous membranes. Remember, opioids kill by suppressing the drive to breathe. In managing opioid overdoses, your primary role is to evaluate their breathing and make sure they are breathing deep enough and fast enough. If they're not breathing deep enough or fast enough, you need to supplement their ventilations with a bag mask or a mouth-to-mask technique. And also be ready to clear or suction their airway. So if you're planning on giving naloxone, you need to have suction equipment handy, and also even for other overdoses, you might need suction equipment as well. Naloxone is a narcotic antagonist, meaning it competes for the same receptor cells in the brain as the opioids. Naloxone is a generic name, and here in a few slides we'll talk about the naloxone that you'll likely be using. But naloxone has a couple of different brand names as well. Narcan is one of the brand names, and Narcan makes a nasal spray that's out on the market. And also there is an auto-injector called Evzio, which functions very similarly to the EpiPen. And if your fire department does get either of these types of medications, feel free to get with us and we will show you specifically how to use them. So we'll look at a little bit of pharmacology for naloxone. Its indication is respiratory depression from a known or reasonably suspected opioid overdose. There's not a lot of contraindications to the medication, except any non-opioid overdose or respiratory depression. Remember, naloxone only works on opiates, and if the patient has any allergies to naloxone or its additives. Some side effects you may see from the naloxone administration are that it may cause opioid withdrawal, and you may see some of those withdrawal symptoms. It may cause hypotension, hypertension, or fast heart rate or tachycardia. It also may cause dizziness and headache. The adult dose for intranasal naloxone is 2 milligrams, given 1 milligram in each nostril. It's important that you not give more than 1 milliliter in each nostril. And in the naloxone that you'll likely be using, it'll probably be supplied in 2 milligram pre-filled syringes, and those are 1 milligram per milliliter. So by giving 1 milliliter in each nostril, you'll be giving 2 milligrams total. The pediatric dose is a little bit more difficult to calculate. It is 0.01 milligrams per kilogram. Naloxone can be repeated in 5 minutes if no change is noted. Higher doses of naloxone may be required if the individual has had very high doses of opioids. This also applies to if they've had fentanyl or carfentanil. However, if they're using heroin, you won't know what that's cut with, so you may not know if they've actually used fentanyl or carfentanil. If the naloxone is successful, it may need to be given again. Naloxone has a shorter half-life than opioids do. Half-life is how long the effect actually lasts. So naloxone is shorter lasting than most of the opioids. So now we'll start discussing the actual administration of the naloxone. It's important that before you try to start giving it, that you have your supplies and your equipment nearby. You'll need the naloxone pre-filled syringe, which is likely to come in this orange box you see here, as well as the nasal atomizer, which you see to the left of the box. The first step is to make sure that you have the right medication. Always verify that you have naloxone, and you can see where that's at on this orange box. Second step is to make sure that it's not expired. And I know this picture may be a little bit difficult to see. This is on the end of that orange box, and one end has a white flap on it, and the top number on this is a lot number, and the bottom number is the expiration date, and you can see it says 2-15, which indicates that this naloxone expired in February of 2015. Step 3 is to remove the syringe and medication plunger from the box. Here in the photo you see on the right side you have the medication ampule, and on the left side you have the syringe. In step 4, we remove the caps of the syringe and the medication ampule, and if you will hold it as it's indicated in the picture, use your thumbs to push up on the yellow syringe on the yellow cap on the syringe, and the purple cap on the medication ampule. Those caps will pop off. The next step is to assemble the syringe, and to do this, you on the ends where you have taken the caps off, the ampule screws into the syringe, and you will see that being done on the left side there. On the right side you see the assembled syringe, and it still has the yellow cap on the end where the nasal atomizer will be applied next. So next we apply the nasal atomizer, and the atomizer goes on the tip of the syringe. You will remove the yellow cap as you see laying down here below in the picture here, and the nasal atomizer then screws on with like a fourth of a turn of the atomizer onto the syringe. Next you're going to actually administer the naloxone with the nasal atomizer, and you can see in the top picture of the medication ampule, below the naloxone label you will see a graduated markings on there that will show you where 1 milliliter and then 2 milliliters is at. So you would give 1 milliliter in the first nostril, stop, and then put the atomizer into the second nostril and give the second milliliter. The bottom picture here shows you on the top side of the naloxone label, it's actually marked with the concentration of the drug, which is 1 milligram per milliliter. The entire ampule contains 2 milligrams, and that's 2 milliliters. So you see that there. In the picture on the right hand side, you see the atomizer placed into the nostril of the patient. So our goal with naloxone administration is to keep them breathing. Remember, opioids depress the breathing centers in the brain. So our goal is not necessarily to wake them up or to make them normal. Oftentimes, if someone is actually addicted to the opioids, this can actually cause them more harm than good to wake them up because it may put them in withdrawals. So it's important to give enough just to keep them breathing, not necessarily to make them normal. So you might ask, what are the possible responses to naloxone? Well, the first thing that could happen is nothing. This may indicate that they haven't taken an opioid, or that the dose is higher than the naloxone will reverse. And there's really not going to be, there's not going to be a way for you to really know that unless you have medication bottles handy that show that it's not an opioid, or someone tells you exactly that maybe they took or whatever. The other thing that could happen is that you may put the individual into opioid withdrawal, and some of the symptoms of this is going to be nausea and vomiting, runny nose and sweating, a fast heart rate, shakes or tremors, agitation, irritability, or restlessness. So the next thing I want to discuss is opioid overdose in the presence of cardiac arrest. So the whole idea of first responders using naloxone is to prevent cardiac arrest. Naloxone is not used to treat cardiac arrest, even if the cardiac arrest is from an opioid overdose. So if someone has gone into cardiac arrest, the naloxone will not do any good when they do not have a pulse. And to show some of this, show some of the evidence, the American Heart Association, all the way back to 2005, has made this point very clear in their guidelines every 5 years. In 2005, they said there is no good evidence to suggest that naloxone improves outcome in the patient with an opioid-induced cardiac arrest. In 2010, they stated regarding opioid toxicity, there is no data to support the use of specific antidotes in the setting of cardiac arrest due to opioid overdose. Resuscitation from cardiac arrest should follow standard BLS and ACLS algorithms. And looking at the last point here, in 2015, the American Heart Association said patients with no definite pulse may be in cardiac arrest or may have an undetectable weak or slow pulse. These patients should be managed as cardiac arrest patients. Standard resuscitative measures should take priority over naloxone administration. So now let's review the actual protocol. The clinical indication for the naloxone is a patient where there is evidence or a reasonable suspicion that the patient is suffering from an opioid overdose. This may be a history from a family member, a bystander, first responder, drug paraphernalia that you find, fresh needle marks that you notice, or medication bottles, or any other type of suspicious evidence. Signs and symptoms of an opiate overdose. Remember, all symptoms may not be present. These are apnea, or not breathing at all, unconsciousness or a severely decreased level of consciousness, lethargy, pinpoint or small pupils, cold clammy skin, or cyanosis, which is a bluish tint around the lips or the nail beds. For the EMR and EMT, the protocol states to initiate a primary survey, which is evaluating the airway, the breathing, and the circulation. If they're pulseless, go directly to the cardiac arrest protocol and begin chest compressions. If their breathing is less than 6 times a minute, begin ventilations with a bag valve mask or pocket mask and supplemental oxygen if you have it available. Give intranasal naloxone with a nasal atomizer. Titrate to adequate respiratory rate and depth. Remember to give no more than 1 milliliter of fluid in each nostril. Be prepared to suction the patient's airway. Continue to ventilate patient as necessary. Reassess continually. Determine if the naloxone was given prior to fire department arrival and how much. This may have been given by a family member or a bystander. And also report to the transporting EMS agency how much naloxone has been given and who gave it, whether it was the fire department or bystanders. So on this slide you see some of the references that I used. The information, especially statistical information, was retrieved from the Centers for Disease Control, Indiana State Department of Health. Also the 2 commercial products, the Narcan nasal spray and the Evzio, have information on their websites as well. Some of the material was adapted from a presentation called War Against Drugs from Dr. Michael Kaufman in Indianapolis. Okay, so at this point, we're finished with the presentation. Prior to giving naloxone in the field, you should practice with your training officer or someone else who's doing the training to assemble the medication syringe, assemble the nasal atomizer, and then practice giving the medication with a mannequin. If you have any questions following the presentation, feel free to contact me. Here's my phone number and email address at Harrison County Hospital. Thank you.